Hi, everyone. My name is Vincenzo Berghella, and welcome once again to another edition of Live at AJOGM FM, the Pink Journal. It's my pleasure today to go over distinguished authors here at our journal on the issue of cesarean delivery for most, which is kind of a provocatory title, but we'll go over the differences between outcomes for planned C-section and planned vaginal delivery, and talk about birth weights and pelvises, etc. Let me get the panel here introduced. Tanvi, do you want to introduce yourself? I'm mute.
Sorry about that. My name is Tanvi. I'm a second-year OBGYN resident at TriHealth in Cincinnati, and I'm originally from Pittsburgh and went to med school at Jefferson in Philly.
Julia?
Hi everyone, I'm Giulia Bonanni. I was born, raised, and trained in Italy, in Rome, and now I'm in Boston for a postdoc research fellowship at the Maternal Fetal Care Center of Boston Children's Hospital. Thank you, Dr. Bergala, for this opportunity of discussion.
No, thank you. Vicky? You're muted.
Hi, everyone. I'm Vicky Ottawali. I'm a current first-year fellow at Brown University. I'm originally from DC, and I had the privilege of training under Dr. Bergella for 4 years of residency.
Michaela?
Yes, hi, I'm Michaela Pavlichev. I am an evolutionary biologist at the University of Vienna, Austria.
Sam?
Hi, everyone. My name's Sam. I'm a third-year medical student at Jefferson, and I'm initially from upstate New York.
Great. So I'll give you a 1 minute background to this. I'm actually lucky enough to have 4 kids. They were born 26 years ago. 40 weeks, 5 days. Back then, resisted induction at 39 weeks. What a mistake. It's amazing how things change over time. But, we didn't allow an induction, eventually spontaneous labor, 5-6 hours of second stage, and that ended up in a C-section, 8 pounds, 8 ounces, mom is well, baby is well. Second baby, eventually 8 pounds, 6 ounces, went into labor at 3 days after due date. Again, the time before the ARRIVE trial, how things have changed, but no induction, was being done at that point for just gestational age. And eventually TOLAC, trial labor after C-section, another C-section. So that was my experience a while ago. I'm actually remarried. I have 2 young kids. I married an OBGYN, and she wanted a cesarean delivery on maternal request at 39 weeks. So we have 2 babies, and that's what happened. So to this day, I'm not really sure which one is right or not, and I'm trying to answer it first and foremost for my learner personality. The most important thing is at the end, everybody's well and good, and the moms are good, and the babies are great. But it is a big question. Do you deliver by C-section or do you have a natural birth? And to go over that, Vicky will present a meta-analysis published in the Pink Journal. Tanvi will go over preferences of OBGYNs and midwives. Sam will go over birth weight data in the US, while Julia will go over birth weight in the world. Again, Julia's work has been submitted. That has been published in the Pink Journal. And Michaela finally will go over the fact that pelvises may not be getting bigger. And that work was published wonderfully in AJOG in the Great Journal. So with that, I will pass it along to Vicky so we can have some data and put some perspective, evidence-based perspective on the issue of planned C-section versus planned vaginal delivery.
Thank you again, Dr. Bergella. So I want to talk about an article that was published in October of this year entitled Planned Cesarean Delivery versus Planned Vaginal Delivery, a systematic review and meta-analysis of randomized control trials. So in this paper, we wanted to look at all randomized controlled trials that compared C-section to vaginal delivery. And instead of comparing each mode of delivery with a specific indication, we wanted to see if we could comment on the overall safety of the 2 major modes, cesarean, vaginal delivery. So the primary outcome was perinatal and maternal mortality, and that included stillbirths, neonatal deaths, and infant deaths from randomization to 5 years or the end of that trial's follow-up period. We also looked at short and long-term maternal morbidity and short and long-term perinatal morbidity as well, which included breastfeeding rates, incontinence, and several other outcomes. So in other words, we basically wanted to see if we can comment on the ultimate question, what is better, C-section or vaginal delivery? And this is not just an academic exercise. As a research team in the early stages of this work, we all could recount stories that patients have asked us, what should I do, C-section or vaginal delivery? And at times the answer was simple because there was a certain medical indication that strongly suggested one mode over the other. And other times we had strong patient preferences that helped us point to one mode or the other when the medical indications were a little bit more gray. But what happens when a medical indication isn't there and your patient just wants to know the level 1 data that exists for each mode of delivery? And so we attempted to answer that question with this paper. So in order to do so, we searched 5 clinical trial databases from inception to August of 2022. We identified trials from 1975 to 2014. They represented patients from all over the world, and the indications that were included were breech presentation, twin gestation, eclampsia, prior anal sphincter tears, prior cesarean deliveries, umbilical artery pH, preterm and breech gestations, and then maternal HIV positive status. The initial search yielded over 5,100 studies after removing the duplicates, and then we searched the titles and the abstracts and screened them. 48 full text articles were then selected for review, and then of those 48, we had 24 that met inclusion criteria, and those 24, there were 15 primary randomized controlled trials. So a total of 15 trials meant 6,618 pregnant patients that were identified to be relevant and included in this meta-analysis. Data was extracted and reviewed by a total of 3 authors, and we used the RevMan 5.4 program to do our meta-analysis. And in terms of demographics, both groups were similar in terms of AMA status, nulliparity, and prior C-section. Now on to our results. When considering the best mode of delivery, there were no differences in maternal deaths between planned cesarean and vaginal deliveries. And we also found that there were no differences in neonatal deaths between planned cesarean and planned vaginal deliveries. So we did do a subgroup analysis, however, of all singleton pregnancies and singleton pregnancies at or beyond 36 weeks gestations. So among singleton pregnancies, cesarean delivery was associated with lower rates of perinatal deaths than vaginal deliveries. We saw 0.69% in the C-section group versus 1.81% in the vaginal delivery. There were no differences in perinatal mortality when just looking at singleton deliveries in the greater than 36 weeks group. Now, next we're going to talk about our significant secondary outcomes. So patients in the planned C-section group were 30% more likely to end up under general than those in the planned vaginal delivery. And patients had 73% less likely chance of getting triple I in the planned cesarean group than the vaginal delivery group. Patients were 61% more likely to get a wound infection in the planned C-section group. And we also saw a 3% decrease in breastfeeding at 1 month in the planned C-section group. So we also looked at several forms of incontinence, including flatal, fecal, and urinary incontinence. So these were all patient-reported measures, and they looked at the course of 3 months, 1 to 2 years, and then greater than 18 months. And there was only significance found in the urinary incontinence group at 3 months or less and 1 to 2 years. So patients were 29% less likely to have urinary incontinence at 3 months or less, and then 23% less likely to have urinary incontinence in 1 to 2 years. And we define this very broadly, but it basically required symptoms to be present for at least once a week. So lastly, for the maternal outcomes, I want to discuss painful perineum or perineum pain. There was a 36% less chance of having perineum pain in 2 years in the planned cesarean group. So now we'll move on to the neonatal results. And so we saw an 82% decrease in low umbilical artery pH in the cesarean delivery group. And then we also looked at birth trauma. And so birth trauma was defined as any kind of spinal cord injury, basal or depressed skull fracture, fracture of the long bones, or any injury to any peripheral nerves present at time of delivery, 72 hours of age, or at discharge from the hospital. And neonates had a 54% less chance of having birth trauma in the planned cesarean group. So tube feeds were significant if required for 4 or more days. And then if it was required for any time beyond that, it was a serious neonatal morbidity. And so neonates were 64% less likely to require such tube feeds in the planned cesarean delivery group. And hypotonia had to be present for 2 or more hours and to be considered serious. And infants were 89% less likely to experience hypotonia in the planned cesarean deliveries. So now for just our summary. Here's a summary table of our significant secondary outcomes. So that middle column represents the outcomes that favor planned cesarean delivery, while the rightmost column favors a vaginal delivery. In the perinatal outcomes, all of our significant data favored a cesarean delivery. So overall, there are no differences in neonatal or maternal mortality unless considering just singleton deliveries. And then C-sections were less likely to result in birth trauma, hypotonia, tube feeds, and low umbilical artery pH. We also saw that C-sections were less likely to result in triple I, urinary incontinence at 3 months or less, and also at 1 to 2 years postpartum, and perineal pain at 2 years. So there's no clear recommendation for or against one mode when considering our study, but I think our subgroup analysis definitely should be considered. Based on these results, we must think about our patients' childbearing goals. Some patients want 1 child, others want 10. We also need to think about future morbidity and the potential risk of abnormal placentation. And also our patients' medical and surgical histories. We don't want our nulliparous patients who have had multiple abdominal surgeries coming to us with a maternal request, because we know that maybe that risk might be more not acceptable for that patient. And so there are a number of other factors that we have to discuss when thinking about the best mode of delivery. And I look forward to exploring those more after hearing my colleagues. So thank you so much.
Wow, beautifully done, Vicky. That was perfect. A lot to discuss, I'm sure, in our discussion section. I'm going to give time to Tanvi. Why does it look blue like this? You guys see blue as well?
No, it looks normal to me.
It looks good? Okay, go ahead. Go ahead somehow.
Okay, so I'm going to be talking about our article, Obstetrical Provider Preferences for Cesarean Delivery on Maternal Request in Uncomplicated Pregnancies, a systematic review of the literature. So I think we as OBGYNs can all agree that for our moms, generally our guidance is for a healthy mom and healthy baby, ideally through a vaginal delivery rather than a C-section. That's what I counsel in my office, and I think that that's what a lot of my colleagues do as well. But what about when that provider is now the patient? So with that being said, are we following our own guidance? In the setting of an NTSV pregnancy, meaning a nulliparous term singleton vertex pregnancy or otherwise complicated pregnancy, would we request an elective C-section for ourselves, or would we want a vaginal delivery? In other words, are we wanting the same thing for ourselves that we typically recommend for our patients? So in 1996, Al Mufti sought to answer this question by surveying a group of London obstetricians and asking them if they would prefer a vaginal delivery or a cesarean section in a hypothetical uncomplicated pregnancy. They found that a surprisingly large number of providers, specifically 17% of them, would prefer a CDMR or a cesarean delivery on maternal request in this hypothetical uncomplicated pregnancy. With that in mind, many similar studies were performed across the world examining the delivery preferences of local providers. And the goal of our review was to look at several of these studies to evaluate the trends of our provider preferences across time and location. So I'll get into the specific numbers in a few slides, but this figure demonstrates the main point of our review, which is that a large number of OBGYNs would prefer a CDMR for themselves in an uncomplicated NTSV pregnancy, and this percentage has substantially increased across the last 20 years. So now getting into the specific numbers, first I'll compare hypothetical NTSV pregnancies versus providers and their actual pregnancy history. So examining all providers first, 13.5% of them would prefer a CDMR for themselves in an uncomplicated NTSV pregnancy, yet 20.9% of them have actually had a personal history of CDMR for themselves. And then breaking this down by provider, 14.3% of OBGYNs would prefer a CDMR and a hypothetical NTSV pregnancy, yet 25.2% of them have actually already had one in real life. And then looking at midwives, 2% of them would prefer a CDMR and a hypothetical NTSV pregnancy, and only 2% of them have actually had one in real life. So some of the studies further broke this hypothetical scenario down and asked specifically about how the preferences would change in the setting of estimated fetal weight. So in the setting of all of our obstetrical providers, 22.1% of them would prefer a CDMR if the EFW was between 4,000 and 4,500 grams. And this number increased to 46% when the EFW was greater than or equal to 4,500 grams. Again, breaking this down by provider, 26.4% of OBGYNs would prefer a CDMR if the EFW was between 4,000 and 4,500 grams. And this percentage increased to 50.4% when the EFW was greater than or equal to 4,500 grams. And then breaking this down into midwives, 0.4% of them would prefer a CDMR if the EFW is between 4,000 and 4,500 grams. And then this number increased to 20.6% when the EFW was greater than or equal to 4,500 grams. So additionally, some of the studies also looked at what would the delivery preferences be if the NTSV pregnancy was now in a close family member rather than the provider themselves. Among all providers, 28.5% would recommend a CDMR for a close family member. And again, breaking this down by provider type, OBGYNs, 67% of them would recommend it for a close family member, and midwives, 0% would. So additionally, some of the studies also tried to examine the reasons that some of these providers would request a CDMR in this hypothetical pregnancy. And in the red box is the top 3 reasons. The most common reason being that these providers believed that it would prevent damage to the perineum and pelvic floor. The second most common reason being fear of harm to the baby, specifically in the setting of a vaginal delivery. And then the third was the desire for a timed delivery. So in conclusion, our study specifically looked at examining the trends of obstetrical provider preferences in the setting of a hypothetical NTSV pregnancy. What our review found was that 14.3% of OBGYNs would prefer a CDMR in an NTSV pregnancy, and this trend has increased over the last 20 years. Additionally, a quarter of OBGYNs have had a personal history of CDMR, and 67% would recommend it for a close family members. On the contrary, though, less than 2% of midwives have had or would recommend a CDMR. Thus, in order to ultimately decide on an evidence-based recommendation on which delivery method is best in an uncomplicated NTSV pregnancy, randomized controlled trial data is necessary. Until then, though, at the very least, we as providers can examine our own preferences and think about whether or not they differ from what we routinely counsel for our patients. Thank you.
Wow, the more I look at this data, the more interesting it becomes. Tanvi, very well presented. You guys are such wonderful presenters. Really, really well done. I'll pass it on to Sam now, who's going to look at birth weight in the United States.
Yeah. Hi, everyone. So I'm going to be presenting birth weight is increasing in the United States. So I kind of gave away the punchline there, but I'll go through some more of the details. So the background and why we were curious about this is that there's been increasing rates of diabetes and increasing rates of obesity. And this is known to have resulted in an increasing number of large for gestational age neonates. As we talked about, the rate of C-sections is also going up in the US. So we hypothesized that birth weight might be a reason for this. So back to our main question, have birth weights increased in the US over time? So our design was a retrospective cohort study. We looked at publicly available birth data between 1972 and 2020. And we calculated this on 10-year intervals just because of the vast amount of data. So we calculated 1972, 1982. We also included 2018 just to account for any effect that COVID might have had on the year 2020. So we calculated the mean birth weight at each interval year and each gestational age, and this will be more clear when I show the figures. And then we calculated the linear model for each gestational age, and our main metric was whether the slope was positive, and if it was positive, we did a t-test to see whether it was statistically significant. So for our inclusion criteria, we looked at singleton births between 37 and 0 and 42 and 6. And we excluded multiple pregnancies, pregnancies with unknown gestational age, and pregnancies with unknown birth weight. So here you can visually see our data. So here you can see the data ranging from 1970 to 2020 and separated out for each gestational age. And the gestational ages with the asterisks had statistically significant positive slopes. And interestingly, the 37 weeks was a statistically significant decrease in slope. And 19 million, over 19 million individuals were included in this study. We only had to exclude about 1% of the data because of missing data. And we also looked at ethnicity data after 1992, just because that's when it became available. So you can see our main results were that the overall trend, when not separated out between gestational age, so overall 37 to 42 weeks, that was a statistically significant increase in slope. And also 39 weeks, 40 weeks, 41 weeks, and 42 weeks separated. It was interesting because the non-Hispanic Black groups and the Hispanic groups also showed those trends. They mirrored the overall trends, but they showed a higher slope. So those birth weights for those groups are increasing at a more rapid rate. And we definitely need to do some more investigating to separate that out in further studies. So this is just kind of a better view, more zoomed in of the figure on the last slide. I want to point out that the birth weight didn't increase by a large amount of grams. It was actually only about 65 grams for the 37 to 42 weekers. But we were worried about the slope and it being positive and the effect that that might have over long periods of time. So in terms of what all this means, one thing we were curious about is why did the birth weight at 37 weeks decrease when all the other birth weights seem to increase? And this could be for a few reasons, one of them being changes in guidelines on the timing of delivery that's happened over the last decades. And then also the method of calculating the gestational age. That was something we struggled with throughout this study, is that different years, earlier years used different measures of gestational age, such as last menstrual period versus ultrasound, and it was hard to kind of standardize that through all the years. Other results that were interesting from our analysis were that the rates of gestational diabetes increased from 3 to 8% from 1992 to 2020, and the BMI increased over a point from only 2012 to 2020. So those were interesting additional statistics that came out of our research. And kind of the takeaway points here is that birth weight is increasing among those born from 39 to 42 weeks of gestation. And the increase in these birth weights may be a factor in the persistently high cesarean delivery rates despite national campaigns. I talked about some of the limitations, but the main ones were that the data collection evolved during the entire study periods, and that estimates for the gestational age have become more accurate as time has gone on, with first trimester dating ultrasounds, which obviously were not available in 1970. And that is all for me.
Sam, that is fantastic, especially when you did this work with Emily Oliver in the first 2 years of your medical school. I'm sure every resident director who's listening to this is taking your name down, among other things. Anyway, next presentation, still staying on birth weights, but now looking globally. Before it was the last 50 years in the US by Sam, and now Giulia Bonanni is looking at term birth weights globally. Giulia?
Yes, thank you. So with Dr. Bagela, we aim to assess global trends in mean birth weight at term as reported in peer-reviewed literature. So we search PubMed and Bayes and Web of Science for ecological and observational studies reporting mean birth weight at term over time as a continuous numerical variable. And we have any restriction based on language or geographic area. We screened more than 6,400 papers and finally included 29 papers in a review. And quality assessment was done with the default and color checklist for ecological studies modified by Veteran et al. We first performed a univariate linear regression model that found a significant correlation between mean birth weight at term over time. And we then introduced dummy variable for continent in model 2 that confirmed this statistical significant correlation. When we in model 3, we performed a sub-analysis on studies that had only national data sources. This peculiar study did not bring any significant data since it was only 43% of the studies. And finally, we did a sub-analysis with data from only 1950 onwards, and this confirmed a statistically significant correlation, which is the graph reported here on the right. So all data pointed to a significant increase in global term birth weight. We must consider strength and limitation. Of course, since we did not have any restriction from geographical language factors and the research was back to 1950, we had access to a very wide range of data. We also adjusted for continents, so we assessed for continent variation. Also, we focused on babies born at term. So this means we limited the influence of eventual different obstetrical practices in different countries. Also, we have to consider some limitation. First of all, the data sparsity, since we included studies from different periods, we had a lot of data sparsity, which did not consent a meta-analysis, and this was the main limitation. Even for external validity. We had a lot of data source diversity, since some study took data from national databases, other from hospital registries. So this introduced sample size variability, and also the study quality was very heterogeneous. Overall, this is a novel contribution to the literature, and another a very good meta-analysis was the one by Blanco et al. Here in the lower left corner, where they state that the number of low birth weight babies, decreased globally between 2000 and 2015. And these support the hypothesis that maternal anthropometry changes, reduced cigarette smoking, and shifts in social demographic factor could be contributed to an increase in fetal and adult body sizes over time. So another important things to consider is also if pelvis are getting smaller over the last few millennia, and an expert will talk after me, so I will not go into that. But also another factor to consider are the long-term complication of multiple C-sections. So we are going to do a systematic review of meta-analysis in the next few weeks on how stable a women's fertility intention over time. And this is important for an OB provider, just to understand if a woman's at T=0 state, her fertility intention, how stable and how consistent are these over time, and to understand if they actually predict some childbearing outcomes in a global cohort. Thank you. The audio is, you have the mic deactivated, Dr. Bergella.
Thank you. Wonderful job, Julia. I was saying great presentation, and this opens up some ideas for discussion. But before that, we have the last presentation, but certainly not the least. We could spend days working on this subject. So Mihaela, and take it away on evolutionary aspects.
Thank you. This have been already great. So I will add the evolutionary aspect to this, to the delivery, perhaps, and some some thoughts on that. So you might ask, why would evolutionary biologists think about medical problems at all? And apart from being interested in variation, including pathological variation, of course, the short answer to that would be that given the selection, given that natural selection exists, why do we still have diseases? Why do we still have pathologies, right? So observation connected to birth is, of course, an old one, namely that human among our close relatives has actually a very close cephalopelvic fit, and obviously that can lead to a lot of risk giving birth. And so the question would be, why did female pelvis not evolve to be broader and therefore safer for childbirth, right? And the most widespread evolutionary explanation to that involve evolutionary trade-off. That means that a structure or a physiology is evolved to serve more than one function, and those functions might be under different selection pressures. In terms of the childbirth, that would be of the pelvic shape, that would be a compromise between upright locomotion on the one hand, and particularly large-headed neonates on the other hand. This is what is usually called obstetric dilemma, and I'm sure you're aware of a lot of discussion on this topic lately. But in any case, the idea of this dilemma is that there is no evolutionary change because there is a trade-off between selection pressures, and there's a lot of work, recent work done, many recent refinements that what exactly this selection due to bipedalism is, that would select for maintaining a narrower pelvis. It might be the original idea is it is efficiency of locomotion, but of course it also might be the stability of female pelvic floor, stability even of male pelvic floor that has a side effect on the female side, and so on. What we have added in our 2020 paper in AJOG is an idea that really is an idea of my brilliant colleague Philipp Mitterrocker here in Vienna. And it's a little bit of a different kind of explanation that does not exclude the previous ones. And that is that the trait itself might be limited in ability to respond to selection. And let me explain what how that would look like. If you now here consider just one axis of variation that I will call disproportion between the fetal size and the childbirth canal, and the values that are smaller than 0 would be no disproportion really. The child fitting through the canal would be just very nicely would be 0, and the bigger values would mean disproportion, cephalopelvic disproportion. If we now add the y-axis, we would think about fitness. And what that means here in simplified terms is that usually we think of babies that are bigger to be healthier, to have a greater likelihood to reproduce themselves later, and so we have this increasing fitness. And in the normal case, without C-section, of course, in the natural case, this curve would go just very abruptly down to 0, namely when the childbirth cannot happen. And so the selection would work to increase fitness, so it would work towards that limit. However, most of our traits, or practically all of our traits, are distributed symmetrically. So this cliff edge cannot really be approximated by the distribution of trait values. without having some part of the population that practically falls off the cliff, so that is bigger than can be born. So that is what we mean with there might be an inherent limit to adaptation here. So we can perhaps make this distribution narrower, but we cannot make it asymmetric. That's just the way how inheritance works. So we would always expect some portion of population, no matter how well evolution works, to be bigger than can be born. This kind of thinking, if we are right in this model, if all the assumptions are correct and so on, this kind of thinking does have an implication, a future implication, and that is that if we remove that cliff by C-section, the curve, so the mean value of the disproportion, might be moving further on along that curve towards a greater disproportion on average in the population. One thing that I need to really warn against is that one assumes that the increase of the C-section in a population that I think we are mostly observing influences this dynamics directly. It's really only the cases where we have a C-section that is done because of actual obstructed birth. Only those cases would contribute to this dynamics. And that is already what I wanted to share today. Thank you.
Wow, fascinating, Michela, really fascinating. So we can open it up to discussion now. We saw the meta-analysis data by Vicky, to just recap it, which again is not all about nulliparous women, singleton, vertex, and term. We talked about preferences, which I was very surprised when we looked at the data with Tanvi, that 1 in 4 obstetricians wants a C-section for themselves. Birth weights, clearly, both two different data sets, world and US, from Julia and Sam. So babies are getting bigger, and it will make sense. We talked about obesity and diabetes and diet, etc. We can expand on that. And then the pelvis, may not be getting bigger, but maybe C-section is changing that. Maybe the first question is for you, at least for me, Michela, to just break the ice. Is there any data that C-section for what we call cephalopelvic disproportion, for the baby not fitting into the pelvis, changing evolution, so to speak?
It's really hard to measure that because the conditions are changing so much. Mm-hmm. So it's very hard to know even in which cases there is cephalopelvic disproportion, and I keep hearing it's actually less than one would think, that a lot of need for C-section is due to different other problems, like not descending or so it's of course it's a question. One thing that we do find is that there is inheritance, so which is needed for this particular model. So that there seems to be that the daughters that were themselves born needing C-section, also they need C-section when they give birth. So that there is a tendency there, but to know whether the any increase of the need for C-section might be due to this model, that's very hard to say.
Because C-section has been safe really for only 50 years, around for 100 some years, and you could think that her grandmothers could have died, maybe 200, 300 years ago, if the pelvis was small. Now small pelvis, but they have a C-section. They pass it on, like you say, to the daughter and then to the granddaughter. Sure. So it's an interesting concept.
Yeah, I think it's overlain with a lot of other you know,
Sure.
dynamics, and so it's hard to see. Yeah.
Do we know if the pelvis over, millennia, I guess, we do know that it's getting a little smaller in terms of
I, I
diameter.
I actually am not aware of that data. Pelvis in general is doesn't preserve very well, so it's a little bit hard to it's easy to, if you actually have the real measurements, then of course that would be nice to see, but uh, over longer times it's not like skull where we actually have quite a bit of data.
Yeah.
Yeah.
Vicky, one thing, and again, everybody can ask questions. I don't want to monopolize, but one question that comes up, in your meta-analysis that is getting a lot of attention, um, getting letters. If somebody wants to write an editorial, we're going to get a lot of interest. Is the fact that, and you said it very clearly in the paper and in your presentation, that this does not pertain only to, again, nulliparous singleton term vertex, pregnancies. That some of those were breech and some were twins. I think that one could make the case that maybe maternal outcomes like incontinence, etc., may not be affected as much, by a breech versus vertex, perhaps, versus perinatal outcomes. The baby outcome clearly may be more dangerous for a breech baby to go to a vaginal delivery than a vertex baby to go to a vaginal delivery. And unfortunately, it's hard to look at. I think you looked at singleton only and showed some benefit. But can you expand maybe on that thinking?
So it's interesting because I think a lot of times the maternal part of this is not really considered. And I think, because thinking about Tomvi's work, and the types of providers who wanted C-sections, there were urogynecologists there, like people who actually really see the sequelae of some of these outcomes more than we do. And a lot of times, a lot of birthing persons weren't even voicing the amount of distress they were in due to these obstetrical injuries. And so I think it's, even though vaginal delivery is physiological, it doesn't mean it's not without harm. And I think a lot of times that kind of damage can end up resulting with a lot of just not no satisfaction in terms of like satisfied with living and with like different things. It's interesting that it sounds like, Dr. Rigo, people want to discount maybe some of the maternal outcomes, or do they want to, or is it kind of like, I'm interested in exactly what they think, because these are patient reported, which I thought was really interesting. And so these are people saying that this is what I'm dealing with, and this is my life after having this vaginal delivery.
Yeah, and I think we're just opening, I think, a Pandora's box. Between the Tanvi. Feel free to jump in, Tanvi. We as a profession in obstetrics, we really care about, for example, the primary C-section rate, right? Nulliparous. And we as hospitals and providers were actually judged by that. Some insurances don't even pay us as much if our C-section rate is, primary C-section rate is 30 or 40%, is too high. And somebody could go around and say, I have a 17% C-section rate, I'm better than you that has a 20, it's better than you at 25. But at the end, I think that one point that we need to make sure comes out is that it's important really to have a healthy mom at the end, a healthy pregnant individual, and a healthy babies or babies. We didn't. I think maybe Julia brought it up that obviously we also need to look at the next pregnancy. And after 3 sections, the risk of accreta goes sky high, and that's really extremely dangerous. But I guess I'll throw it out there now. I was going to do it later. One idea I have, I've been floating around to the Maternal Fetal Medicine Youth Network from the data you presented, is that since we don't really have much data on this, finally we could figure out if for again nulliparous singleton term vertex, low risk um, um, woman, if a C-section is better than vaginal delivery or a vaginal delivery, it's better. And I think it would be, good to focus, for example, on a 35-year-old who may want to have or may have time to have only one or two babies, and then look at composite neonatal mortality and morbidity, which actually is not trivial. This is from their RIDE trial from the network. It's 5% or maybe even a little bit more, and composite maternal morbidity, including pelvic floor. With a vaginal delivery, you can have OASIS, the severe perineal lacerations. Uh, I believe actually the data that Vicky showed that, if you have a vaginal delivery and you push for a while, you may have a little bit more incontinence, and issues like that. So there's a pelvic floor network that I hope could look at this, and then really what you need to do is you need to follow up to reproductive life, because even if somebody thinks that maybe a C-section, if you have one baby, may not be so bad. Um, I think if you're a 20-year-old and you're planning to have 5 babies or 10 babies, which is great, I think maybe a vaginal delivery will be much better option given the accreta and surgical risk from multiple C-sections. So um, I think that kind of there's so many aspects, difficult to discuss, but I think we could add more level one data to this discussion. Any thoughts?
I kind of wanted to piggyback
Yes.
off of something. Oh, sorry about that.
Go ahead, Delby.
I was going to say, I kind of piggybacking off of what Vicky said. I was talking about it with a colleague earlier and asking, well, why would midwives in the setting of like a macrosomic baby want, be okay with trying a vaginal delivery, but more OBGYNs would prefer a C-section. And I think it kind of comes down to recency bias. Like I think we were mentioning earlier, as obstetricians, we're probably the ones that are handling a little bit more advanced or riskier cases. That's just the nature of, being an obstetrician. And midwives generally tend to handle the more kind of straightforward, easygoing pregnancies. So they're probably not seeing the results of, a macrosomic baby that, leads to a horrible fourth degree that then, leads to wound breakdown and, so on and so forth. But that's something that we as obstetricians are generally following and kind of have that background, maybe guiding and influencing our decisions or preferences for ourselves. And then something else too that I wanted to comment on was, Vicky, you mentioned it towards the end of your presentation, that generally assessing risk for each person is important. And Dr. Bergella, you were saying the same thing, like a 20-year-old who's interested in having 5 or 10 children, taking that preference and, risk into account. Like, let's say they're, BMI of 40, which is not uncommon where I'm training, that might push us more towards maybe, a vaginal delivery is the safest option for you. And, while you can still always, of course, request a C-section on, maternal request, maybe that's not the best option for you. And personalizing that risk a little bit more, kind of like with cervical cancer now, as opposed to just a standard, is this better than this? I think there's a little bit more nuance there.
Julia, I think you
Yeah,
were jumping on.
I was also commenting on Vicky presentation, like the meta-analysis is terrific. I feel like it's a great methodology. And yes, so I was, Dr. Bergala anticipated me, since I was gonna to ask what do you think is the external validity of these on singleton pregnancy? But yeah, I see that actually including bridge presentation also include all these RCTs where breech are randomized to vaginal delivery and then also are uh, underwent an emergency section, I imagine. So what's the external validity? And I think a new RCT as the one that Dr. Bergala is proposing is something we really need right now to understand it better. And also the assessing of long-term complication, that really makes the difference. And also, why, well, just to finish my comment, while Michaela was talking, I also think that we can also trying to assess over time the head circumference, how if it increased over time. I don't know if someone knows of a study about it, but it's also a good idea since what you have said.
Yeah, I don't think it's increasing actually, but I totally agree that we probably need a little bit more personalized decision making. And I was wondering whether there are any other also anatomical um, aspects that might be, taken into account, that would give a little bit of a hint what are these this what's the properties of these pregnancies that do go bad so often. Is there anything that we can look for? And the oldest, I guess, the idea was the shape of the pelvis, right? I mean, the whether it was, the outlet of the pelvis, I guess, of the birth canal. But are there others? Percentage is great, but what is about this percentage of pregnancies?
You remind me of there are some randomized studies that are old. They did X-ray pelvimetry, of many years ago. I'm sure you're very familiar. In some, and randomized some others not to get them. And in the ones that X-ray pelvimetry was known, the only difference in the end that those people got more C-section, because if we think that whatever diameter is not so big, then we get worried. There are also people who are spending their whole career on equations and putting age, because the older, more C-section. In fact, 35-year-olds in the US or older, they have a 40% incidence of C-section. So even if they want a vaginal delivery, right now in the US, it's 40%, their baseline. And BMI, we've talked about diabetes, presentation, not only vertex, but how is the vertex presenting? There are many, gestational age, of course, but as of now, we really don't have.
It's not clear.
Yeah,
Yeah,
it's
it's
not
not
it's not clear.
actually.
And
Yeah,
can we really tell a woman, okay, we put in these 5 variables, so your risk is, that you have a 80% chance of vaginal delivery or only 50%?
sure.
Is that good? Like, or are we causing more harm? Some people think that actually that there is a investigator here at UPenn who's done a lot of work on this. I think Rebecca Hum is her name, and she says, "You look, if your risk is only, it's 80% you're going to have vaginal delivery, you should definitely attempt, and maybe you should really go for it and wait forever and push forever, etc. Versus if your risk is 20% of having a vaginal delivery, you have very high risk for C-section. Forget labor, you're going to have complications in labor, which is not a bad concept. It's not been proven by level 1 data, but that's something that has certainly been hot in our field.
Sure. Yeah.
It's really interesting because I feel like we love vaginal deliveries because it's physiological, which makes sense to me. But then when we think about our pregnancies, some of them aren't. We have like some really fantastic reproductive endocrinologists who can really have like great techniques to get people pregnant that otherwise would never be pregnant. And
True.
so I think that is like to penalize a provider or a hospital for not doing something physiological when really we're presented with patient cases that might not be, or we have great maternal fetal medicine doctors now who are able to get people through their pregnancies with really high risk conditions where 50 years ago they would have never been able to get through the first, second trimester. It's like really interesting to have to balance how we have a new risk pool with this very like risky physiological way of birth. And it's just, I'm wondering now, because I feel like we don't really put into consideration how traumatizing labor can be. and the hospital experience can be. And when we talk about doing harm to a patient, maybe a 5-day induction is more harm than a scar on the uterus with a C-section too. So I feel like now we're all like, go raha for vaginal delivery, but we don't think about the unintended consequences to flipping that patient left and right a bunch of times when they're having a category 2 strip, and then having atonic uterus after 5 hours of pushing and them having to go back and lose their uterus anyway because you can't get control of their postpartum hemorrhage. Like, there's so many things with the vaginal delivery that's really difficult, and we've decided to penalize people if we don't go for it. So it's just fascinating. And plus we have all these other data just showing we have increasing birth rates, smaller pelvis, all these other things. So I feel like on like the financial end, maybe we should reconsider some things too.
One piece of data that resonates with me, we haven't talked about yet, it's that there's good data that shows that up to 10% of women having a vaginal delivery have anal incontinence because of unrecognized, third or fourth degrees or not well repaired third and fourth degrees laceration. So it's I think it's something we need to work more, and I'm hoping that we can do it together with urogynecologists who can do good tests and do it long term. Even people who have a planned C-section can have urinary incontinence, anal incontinence, sexual issues, whatever. So there is a baseline there. You're not going to prevent anything with everybody having a vaginal delivery or everybody having a C-section, but you can certainly have a little bit more, like Michaela is saying, individualized care. And I think at the end of the day, maybe I'll put it up again. It's for, the slide from Vicky. I think having some kind of counseling, and that here, look, here from what we have, here are the risks. You can have, if you're worried about wound infection, have a C-sections. If you're worried about choreo or urinary incontinence, have a C-section. And for the baby, again, it seems like C-section may be better, but maybe if you want to have 4 babies, then this doesn't matter that much, and you should care more about anacrita in your 3rd or 4th pregnancy. So I think doing it that way and giving better individualized counseling, I think it's the way to go, and doing more wonderful studies like yours. Any last comments from any of you to wrap it up? It has been a great thing. I think a lot of people hopefully have ideas of how to further the field and how to improve it. At the end of the day, for me, I really want to see, as I said at the beginning, a healthy pregnancy, a healthy, pregnant mom and postpartum mom forever, and a healthy baby. And I just don't know that, fixating, that a C-section rate at a certain point, it's really what we want, but it's a lot more nuanced, as we've seen today. Really one of the most enjoyable sessions we've had. To kind of conclude, I just want to say that we've had a lot of this live at AJOGM FM now about all kinds of labor issues, as you can see here on the slide, obstetrics issues, twins, progesterone, steroids, etc. The last one, Surclash Technique, was watched by over 2,000 of you. So thank you for being so many following us. A lot of other issues, including even publication and guidelines. So thank you for following us on Facebook, on X, former Twitter, on YouTube and LinkedIn. These are where you can watch us if you haven't watched us live, and also where you can tune in for next sessions. And at the top of the hour, I just want to announce that the next one, we're around holiday season around the world, I guess. We'll discuss happiness with other experts on December 11th at 8 a.m. Eastern. With that, let me thank Julia and Vicky and Sam and Michaela and Tanvi for a great session. Thanks everyone for following. Bye-bye.